Hi everyone, welcome back to Forward Therapy. My name is Kelly. I am a certified hand therapist, and today's video is for all the hand therapists out there. I want to talk a little bit about CMC arthroplasties. I don't think I've ever talked about this on this YouTube space, and so I figured why not? It's like time to make a video about it. So just like a little, hand therapy chat. I think it will be good fun and hopefully it will be helpful. And I look forward to reading the comments below from all of you, kind of talking about what you guys are doing or seeing at your practices. And yeah, let's go ahead and get into it. So the first thing that I think is very important with CMC arthroplasty to know is that there are so many different types of surgical procedures that are out there. The surgeons that I work with right now are primarily doing a lot of LRTIs and suspension plasties, so that's kind of what I'm seeing the most in my clinical practice or with my patients, and they have been doing really well lately. They usually do pretty well overall. It's a long haul, as most of you probably know. I always tell people at their first visit, hey, expect probably 6 months of recovery here, and pain is very common, and everybody has sort of different experiences with that, but generally it is a long, slow heal, and most people have been pretty educated on that, and they end up doing, typically really well, which is great to see. I do think that one of the most important things to do is have a good relationship with your surgeons that you work with, or at least be comfortable talking to them, asking them, making sure that you understand kind of reading op notes and have access to op notes, or if you're able to establish relationships with your surgeons and really understand their preferences, because you want to know kind of what procedure they're doing. That helps you to understand sort of what the symptoms that people might be having, or things to look out for. And then also knowing what your surgeon's preferred protocols or, kind of their post-op instructions, all of that stuff is, because that's very important for, not only just your sanity, but also in steering your patients down the right path and helping get the best outcome possible for them. So I definitely recommend, kind of working with your surgeons on that as well, or at least requesting information on what they are expecting. The surgeons that I work with right now tend to want us to wait for about 12 weeks to start strengthening and discharging of the orthosis. So they're a fairly conservative protocol, I would say, but we are typically starting range of motion, active range of motion, around 4 weeks. And so typically the surgeons I work with, their patients are typically casted for the first 4 weeks, and then they start their therapy about week 4. They come to me with their cast removed. Usually they're in a temporary splint that the PA or the physician has given them. So on my first visit, typically I am, building rapport with that patient. I'm checking out their incision, what that looks like, kind of assessing for hypersensitivity, talking about pain. We're going to assess their kind of active range of motion, look at their fingers, see if they have anything going at their wrist at all, and their thumb at all, starting to assess some of that movement. Of course, looking up the chain as well, making sure they don't have shoulder or elbow pathology going on. A lot of typical assessment things that you might look at. I'm looking at their edema, anything, around that area. And then I usually will make an orthosis at that time as well. Our surgeons often will want kind of both a long and short opponent's orthosis or thumb spica orthosis. I usually start on the first visit with a forearm-based thumb spica, just because I do find that if we push these people too hard too early, their pain is just going to be a lot worse. And so often if we just give them a little bit more stability, a little bit more protection, people tend to be a little bit more comfortable with that. They're not as, painful. Some people are more painful than others, but it does seem to help to start with the long orthosis. And then oftentimes I'll make a short opponent's orthosis at 6 weeks instead of doing them both at once. In my clinic, we get 40-minute evaluations. And so getting the patient comfortable with me, getting through an evaluation and an orthosis fabrication, and then also a home exercise program, I just don't find I have enough time typically to make 2 orthoses in that time. So I usually start with just the longer one, depending on the patient. And then I talk them through kind of an exercise program as well. And usually what I'm starting with kind of at that 4-week point is active range of motion. So certainly I'm going to give them shoulder range of motion, elbow range of motion, make sure they're moving their forearm. I'll make sure that they're moving their fingers, that they, can make a good fist. If that's an issue, then we want to really work on their finger mobility. And then I'm usually starting to have them do a little bit of movement at their thumb. Often what I'll start with is just thumb touches, like touching the index finger and then trying to open the thumb away from the index finger. Just that little bit of motion. It incorporates the CMC, the MCP, and the IP joint. And just starting with a little bit of movement there. You can also have them practice some thumb spreading. I often will do that in the air because remember, after this surgery, often people will not be able to flatten their hand because the CMC joint has been positioned in the most stable alignment in sort of that in between palmar and radial abduction. So most of these people will actually not be able to flatten their hand over time, which is good to educate your patients on so that they're not like forcing the thumb into that overstretched position. But just starting to have them work on some radial abduction or making an L shape. And then oftentimes I'll get them gliding their FPL a little bit, so maybe blocking the MP and doing some IP blocking, or blocking the CMC and doing some MP blocking, just trying to get their thumb moving a little bit in functional ranges. And again, just doing active range of motion, really. We're not passively moving it, we're just trying to do active motion, get them going. I talk a lot about pain management, things like heat, ice, medication that they can talk with their doctor about, potentially some, pain neuroscience education, diaphragmatic breathing is great. It really depends on what pain level they're having, if they seem to have just kind of like typical post-op pain or if they're more kind of out of proportion pain or central sensitization. So all of these are good factors to kind of look for in your evaluation and what you should focus on. I also typically will, talk through scar mobilization, making sure that they're touching the scar and the incision. It tends to be very hypersensitive for some people because of the sensory branch of the radial nerve is really close in that area. And it's also really, tight in that area too. Like we don't have a lot of subcutaneous fat or tissue, so the scars tend to want to stick down pretty aggressively for a lot of people. And we haven't touched it for 4 weeks because they've been in a cast. So starting to have them do some scar mobilization techniques, just getting used to touch. If they have hypersensitivity, I'll start them on a desensitization protocol with textures, having them rub the area with a cotton ball, 3 to 5 minutes, 4 or 5 times a day, really just getting used to touch. So these are all kind of things that I tend to work on. Managing edema, again, ice, elevation, you could consider compression at that point. As long as they can get in and out of a compression glove or a compression sleeve, that often will be something that these patients tend to like. So this is kind of my approach at sort of 4 weeks. And then in my clinic, depending on the patient, again, everyone's different. If they're doing really well, I feel like they're going to do well. They're going to be compliant with their home program. They're exercising. They seem to understand everything. Their pain's not excessive. Their edema is not excessive. Then I'm probably not going to see them for another 2 weeks because they can do a lot of this, through their home program. Our patients have access to us through secure messaging, so if anything comes up sooner, they can always send me like an email through our system, and so that they can, get checked on sooner if they need to. But I usually see them every couple weeks, just because they seem to be doing pretty well. Unless there's complications, of course, or if they have finger stiffness or, X, Y, and Z. And then, again, like kind of 6-week visit, I'm usually making like the short thumb spica orthosis for their hand-based orthosis. I'm having them progress their range of motion, trying to go a little bit further into their movements. Maybe they can start working towards additional fingers of opposition or getting a little bit farther in their range of motion. They're reaching. Watching out for the hyperextension at the MCP joint, because again, we don't really want to retrain that pathway. You can start to do potentially some like extensor pollicis brevis exercises, having them start to do a little bit of work there. Depending on their surgery, sometimes I'll have them start doing some first dorsal interosseous work, doing some bunny rabbits or peace signs, or even, kind of opening and closing the finger so that that first dorsal interosseous gets a little bit stronger. Again, depending patient to patient. And then typically I'll see them again somewhere between 8 to 10 weeks. And then we're usually, if they're still restricted on their range of motion, then we can usually start passive range of motion. They should be partial weight bearing kind of around that time. I usually start them on fine motor coordination retraining. That could be like manipulation of small objects, doing things with small things around the house, having them do in-hand manipulation, all those kinds of skills, great to build. You could do a lot of therapeutic activities, kind of teach them how to coordinate with the thumb and the hand a little bit more. Tennis balls work really great for this too. You could actually put like little alphabet letters all over the tennis ball and have them kind of rotate the ball to touch different letters with their thumb. A lot of great, things that you can find, even LinkedIn, Facebook. A lot of people clinicians have great ideas. But generally, this is kind of like where we're progressing to. And then usually around the 12th week, my surgeons are asking us to discharge the orthosis or kind of have people wean out of the orthosis, and then strengthening and increasing weight bearing. So usually for strengthening, I tend to not give a ton of therapy putty unless these people are like really struggling with grip strength for whatever reason, because I feel like a lot of times with arthritis, people just tend to go to town on gripping, and then it actually kind of stimulates more irritation of their joints and worsening of their symptoms. So I don't usually give them putty. Sometimes I have before, it just really depends. Usually my strengthening program is more focused on dynamic stabilization. So some of the work from Virginia O'Brien or Judy Kolditz or, some of these other amazing therapists and just working on dynamic stabilization. So I like to do kind of the C shape, isometric holds. Those are really great ones. You can do sort of the like kind of little dynamic stabilization. I like to do that on a tennis ball even, just have them kind of like roll their thumb around the side of a tennis ball. First dorsal interosseous exercises, you can have them do some rubber band work maybe where they're, depending on, again, their pain levels, their coordination, their stability of their joints, but working on some extension exercises, abduction exercises. So those tend to be like kind of my go-tos with strengthening, but every patient's different. So you really have to assess kind of what they need over time, and then also what activities they're trying to return to. So this would be time where you can start to help them get back to activity-specific or exercise-specific training as well, and stability. I feel like I just talked for an hour at you, and I know it went by like pretty quickly. This was a lot of information and a lot of just like general kind of chatting at you. I would love to hear what you are doing as a hand therapist or what you're seeing in your clinic, and kind of discuss, kind of your treatment guidelines and protocols and how your patients are doing. Thank you so much for hanging in there. I know this was kind of a long video and probably a little bit boring, but hopefully it was helpful in some way, even if you're just listening to this like on your way to work or kind of like you're chatting with a friend. That's really what I hope these videos kind of are, is like having a hand therapy friend to chat with. So hopefully this video is helpful for you. If you enjoyed it, please give it a thumbs up. I would love to hear your comments below, and I hope to see you all in the next one. Thanks for watching. Bye.